My name is Lorenzo Falchi, and I'm a lymphoma specialist at Memorial Sloan Kettering Cancer Center in New York City. This year at the European Hematology Association meeting in Stockholm, we presented a subgroup analysis from a recently reported randomized phase 3 EPCORE FL-1 trial. We had previously reported the primary analysis of this study at last year's ASH, showing that the addition of epcoritamab to rituximab and lenalidomide resulted in a meaningful reduction in the risk of progression or death compared to rituximab and lenalidomide alone, and it increases the rates of objective responses as well as those of complete responses. So in this subgroup analysis, we wanted to dig a little bit deeper into the data and try and dissect the benefit, the added benefit of epcoritamab in various relevant patient subsets. And, just as a reminder, the trial was a one-to-one randomized controlled trial of patients with relapsed or refractory follicular lymphoma after at least one line of therapy, including chemoimmunotherapy, and patients were treated for 12 cycles with either rituximab and lenalidomide or rituximab and lenalidomide plus epcoritamab. Epcoritamab was given on a step-up dosing schedule during cycle 1 and thereafter weekly for cycle 2 and cycle 3, and then monthly thereafter until cycle 12. And as I mentioned before, the primary endpoint of the study was the progression-free survival and the dual primary endpoint, the additional primary endpoint was overall response rate. In this particular analysis, we focused on patient subsets, including patients categories divided by age, above or over the age of 70, comorbidity scores, in this case assessed by the NHL5 comorbidity score, prior lines of therapy, FLIP score, bulky disease, early progression, and double refractory status. We also did a subset analysis that we found very important, looking at whether the relative dose intensity of lenalidomide could impact the results and also the primary endpoint of the study. So when we looked at patient subsets, we observed a benefit that was preserved with the addition of epcoritamab in patients over the age of 70 compared to those 70 and younger, younger than 70. And in addition, there was no difference in outcomes between these two groups, meaning that the benefit of epcoritamab R-squared was roughly the same in patients across both age groups. Similar observation for the comorbidity index, with all the caveats that each comorbidity index has, no index is really perfect, but we certainly observed, again, a benefit of the addition of epcoritamab over rituximab lenalidomide alone by comorbidity score, whether it's low or intermediate high. And then thirdly, we looked at prior lines of therapy, and this was perhaps an important subgroup analysis because oftentimes I hear that a regimen as effective as epcoritamab R-squared should be used in second line or prioritized in second line. And in part, I agree with that, but we also wanted to make sure that the benefit of epcoritamab was preserved in patients with third line plus follicular lymphoma. And that was certainly the case. And interestingly, there was no difference in progression-free survival between patients receiving this treatment as a second line versus third line plus. So it's very important to note this because at any point where patients may be referred to us, at any point in their journey, if they're fit and candidate for a treatment like EPCORE R-squared, they should probably be prioritized for that treatment. Baseline FLIPI, did not really impact on the results of the study. Patients with high FLIPI had a numerically or seemingly slightly inferior progression-free survival. This perhaps is not surprising, but we didn't power the study to do that analysis, so we really would not want to comment on intra-arm differences. Exactly the same was true when looking at patients with POD24 or early progression of disease, versus those with later progression. And then very similar consideration also, we had when looking at patients with or without bulky disease and patients with or without double refractory status, which means disease refractory to both rituximab and an alkylator chemotherapeutic agent. And so really across all of these patient subsets, the benefit in progression-free survival was clear and unambiguous with the addition of epcoritamab to R-squared. But as I mentioned, we also did an analysis looking at whether the relative dose intensity of lenalidomide could affect the results of the study, because one of the questions that often comes up when debating or discussing the results of this study is whether we really need lenalidomide, which is a drug that has its own toxicity profile, and not all patients may be candidate for them, whether for advanced age or impaired renal function and whatnot. So we did do that analysis. And one of the things we saw is that the benefit, well, the first thing we saw is that the benefit of adding epcoritamab was preserved across lenalidomide relative dose intensity subgroups, in particular in patients with more than 70% RDI versus less than 70%, or more than 50% versus less than 50%. One of the things that we also noticed, though, is that within the epcoritamab group, the difference between patients with higher and lower intensity of lenalidomide seemed relatively pronounced, and a little more pronounced than the same intra-arm difference that we saw in the other risk categories, say POD24, or say bulky disease, or say refractory status. And so it sort of deserved to be fleshed out a little more. And in particular, when looking at RDIs more than 70% or less than 70%, we really noticed that the patients that could receive the triplet, rituximab, epcoritamab, and lenalidomide with a proper dose of lenalidomide, are the patient subset that benefits the most from this treatment. So to the question, can we avoid lenalidomide in this triplet combination, I would answer no. And we should try to do lenalidomide at the maximum dose that the patient can safely tolerate and that we're comfortable with. We also looked at, generally speaking, safety profile and descriptive statistics of adverse event incidence and severity, including some key adverse events, particularly neutropenia, febrile neutropenia, and infections that were the adverse events perhaps most increased with the addition of epcoritamab. And what we saw is that across age subgroups and across different comorbidity index subgroups, that toxicity profile with the addition of epcoritamab really remained the same. And so there didn't seem to be an added toxicity in more vulnerable subgroups, if you will. So that was the kind of last piece of the analysis that we presented. And so as we look at the next data cut point, where hopefully we'll have longer follow-up and could say more about the study results as a whole, just looking at all these subset analysis kind of gave us comfort that really the benefit of the addition of epcoritamab to R-squared is very homogeneously significant across the board, across ages, comorbidity indexes and risk factors, disease or patient-related risk factors, and dose levels of lenalidomide. So I hope this was of help to you as you dissect the data of this very important study, and I'm looking forward to seeing the updated results in the future, hopefully this year at ASH.